This video demonstrates the technique of laparoscopy assisted coloplasty for congenital short colon or congenital pouch colon. The patient was a 6-month-old female child with a window colostomy done at birth. There were no associated abnormalities. 3 trocars were used: the umbilical 5 mm trocar for the telescope and right and left supraumbilical 3 mm trocars for the hand instruments. Here we see the insertion of the sutures for lifting up the abdominal wall for inserting the umbilical trocar. An incision is made in the bottom of the umbilicus with the number 11 scalpel blade, and entry into the peritoneal cavity tested with a hemostat before directly entering the peritoneal cavity with a 5 mm trocar on which a rubber glove guard has been inserted. This is the first view inside the peritoneal cavity looking down towards the pelvis, and we can see the large colonic pouch with its antimesenteric blood supply. This is the region of the fistula where the pouch enters under the uterus to open in the vestibule. This is the insertion of the left supraumbilical trocar. And similarly another one on the right side underneath the liver. The pouch is grasped near the fistula and it can be seen entering behind the infantile uterus, which will have to be hitched up out of the way so that access is provided for dissection of the fistula. As the child is very young, there is not much space in the pelvis, and every maneuver should be utilized to facilitate the dissection. The uterus is hitched up by a transfixation suture of silk which anchors it towards the anterior abdominal wall, and this opens up more space for dissection of the fistula in the pelvis. Dissection is begun with the monopolar cautery hook at the most obvious anterior point with division of the peritoneal bands holding the ovary onto the anterior surface of the pouch. In standard laparoscopic assisted abdominoperineal pull-throughs for anorectal malformations, it is customary to begin the dissection behind the bowel so as to achieve the plane in the sacral promontory at the earliest. However, because of the large external diameter of the fistula, in this case it is better to begin the dissection anteriorly and follow the plane posteriorly, keeping close to the bowel surface. So here we are now moving to the bands on the right side of the fistula, working towards the back of the bowel. One can see how closely the right ovary is applied to the short colon, and It has to be protected from damage. The space inside the pelvis of these infants is really tiny and not affording of much room for error. As we can see, the tissues surrounding the fistula are quite thick and one really has to work one's way through them before the bowel surface is achieved. And care has to be taken that we do not inadvertently open the bowel wall here, as that would immediately lead to some contamination with stools. A lot of peritoneal bands and other tissue has to be divided all around the circumference of the fistula before we can move posteriorly and try to get the plane in the hollow of the sacrum, which is seen opening up here now. It is surprising that the external diameter of the fistula in a case of congenital short colon is so big, whereas the internal opening is mostly pinhole. The large size of the fistula does make for a somewhat more tricky dissection than in normal cases of anorectal malformations being done laparoscopically. The harmonic scalpel has been brought into play here to facilitate the dissection of these somewhat thick tissues, and we can see that the plane in the hollow of the sacrum behind the bowel wall has been entered, and further dissection will continue in this until we reach across the bowel underneath it to the other side. We return to the posterior plane of dissection, progressively narrowing the fistula distally. In all patients of anorectal malformations, and more particularly in those with congenital short colon, it is also important to keep in mind that the ureters are present just lateral to large fistulas. It is therefore important to stay very close to the bowel wall when performing the dissection of the fistula, and if possible to actually pre-visualize the ureters so that their location is accurately known. We can now see that the fistula in its entire width is gradually getting delineated, and it is time to try and achieve a through and through passage underneath the fistula across the mesentery to the left side of the patient. And there you can see the gap appearing, which will be used for this purpose. The straight white structure which is seen coursing downwards is the internal iliac artery. We progressively continue to narrow down the fistula by dividing the bands which are put on stretch in a circumferential manner, going from one side to the other and from posterior to anterior. In a male child, it is important to keep track of the two vasa deferentia. However, in a female child, that is a bit of convenience. It is now possible to appreciate where the short colon pouch is narrowing down and getting converted into the fistula. We can see that we have encountered a bit of bleeding, which is probably due to a surface vessel being torn in the grasp of the toothed grasper. I would really prefer to use a non-toothed instrument for this procedure. However, the width of the short colon and the thickness of the muscle are such that getting a grip with a standard grasper is quite difficult. In the time-honored method of controlling bleeding, we first suck away all the blood to see where the bleeding vessel is, and then control it either using diathermy or the harmonic scalpel. So the vessel is present just under the grip of the grasper itself, and here we are controlling it using the harmonic scalpel. The congenital pouch colon pouch is a very vascular structure indeed, and there are quite a few surface vessels which are amenable to damage. Having narrowed down the fistula as far as possible, we are now proceeding to divide it by cutting it transversely at the lowest extent. It may seem as though the fistula is still not narrowed down as far as we can do it. However, we need to be reminded that the external diameter of a congenital pouch colon fistula into the bladder or the vestibule is almost 3 times that of the fistula size in conventional anorectal malformations. And once you find that there is increasing degree of tissue resistance, and instead of narrowing the fistula you are actually beginning to damage tissue, that is the point when one should stop and cut across the fistula. In order to be very safe with the fistula division, it is better to start posteriorly and enter the lumen as we have just done, and then using that as a guide, cut circumferentially across until the entire fistula is divided. Because of the extensive size of the pouch, clearing it completely of fecal matter is well nigh impossible, and you can see a leakage of small amount of residual stool here, which will subsequently be sucked away to leave a clean pelvic field. So by alternately dividing the exposed wall of the fistula and gently clearing away the small amount of leakage of fecal contents, we are almost through with the fistula division. The last part of the wall, which is towards the left side of the patient, remaining. And you can see how I am rotating the pouch in order to bring the cut edge into clear view and cutting the tissue as distally as possible so as to divide the narrowest point of the fistula. Needless to say, there is a small degree of technical difficulty involved in working with such a wide piece of bowel in such a narrow pelvic space. However, with a little manipulation, it can usually be accomplished. So the last few remaining strands of the fistula are getting divided, and this should free up the short colon pouch from its attachment deep within the pelvis. We can see the lumen, the wide lumen of the fistula, and only a few posterior adhesions remain to be divided to free up the short colon. Another reason for wanting to divide the fistula as distally as possible is that it has been demonstrated that this fistula contains the fibers of the internal sphincter, and we almost always use the fistula itself to form the new anal opening. In patients of congenital short colon or in more conventional anorectal malformation surgery. So here we have detached the final few strands which connect the fistula to its attachment in the pelvis, and after clearing out the little bit of leaked fecal matter, we'll proceed to divide some more of the posterior attachments of the pouch to free up the fistula and the mesenteric border. It is very important to do this so that you can draw the pouch out of the small colostomy wound and do the stapled coloplasty on the surface of the abdomen. As can be seen here, the strands underlying the fistula are quite thick and some of them contain blood vessels. So it is important to carefully dissect each one and control them individually to prevent troublesome bleeding. Here we are just testing the extent of mobilization of the pouch, as it is the very bottom end which is going to reach the perineum as the neo-anus. A good rule is to test this mobilization and then increase it by at least 25% so that there is a tension-free anaplasty on the skin surface. Almost always this estimation from inside the abdomen will fall short if we leave it just at this stage. Having performed the mobilization, we have now mobilized the colostomy and drawn the pouch outside the abdomen. A few remaining strands which are anchoring the pouch to the retroperitoneum are being divided so that the coloplasty can be performed. As a fairly long tube is to be made out of this shapeless mass of tissue, it is important to divide nearly all the vasculature, which will prevent the formation of the tube while at the same time retaining sufficient vascularity that the whole length of the tube remains viable. The junction of the ileum with the colonic pouch is at the extreme left of the patient, and the fistula moves towards the right, which will eventually come to the perineum as the neoanus. The orientation of the tube is important because the mesenteric vascularity has to be left attached to the tube while cutting the pouch. And therefore most of the tissue will be removed from the antimesenteric border so as to leave as long a tube as possible attached to the mesenteric supply. As a guide, a number 10 feeding tube is being put into the fistula to enable the staple lines to be placed accurately. The pouch is held between a couple of Babcock's forceps to steady it before the first stapler line is fired. So you can see that the first staple line has been cut, and now the second stapler is being applied to create the narrow tube. And one can appreciate that the external diameter of the tube is not much more than about 15 millimeters to 17 millimeters. It is very important to make the tube as thin as practical and as long as practical to prevent subsequent dilatation, which is such a common problem after coloplasty in the experience of most surgeons. It is an evidence of the vascularity of the pouch that it manages to bleed even through a double row of staples, and therefore the bleeding points have to be carefully oversewn before the pouch is placed in the pelvis. So making one final check of the patency of the lumen of the entire tube, and also at the same time we make sure that there is free bleeding from the end of the tube, thus signifying its viability. For the anoplasty we are using the anterior sagittal approach, where an incision is made in the sagittal midline from the posterior level of the fourchette up to the posterior border of the neoanus. Keeping an artery forceps parallel to the table and strictly in the midline will lead into the pelvis through the fibers of the levator ani in the time-honored technique of the open abdominoperineal pull-through. It is important to, of course, keep strictly to the midline and also to keep the artery forceps parallel to the table. A finger kept inside the pelvis also acts as a guide so that the tunneling is accurate. The end of the tube is then grasped in the tunneling forceps and drawn down to the perineum, making sure that the orientation of the stapled suture line is correct and there is no twisting of the tube. As we can see, it lands up freely in the perineum, there is bleeding from the edges, and there is a patent lumen. It is therefore a simple matter to perform an accurate mucocutaneous anoplasty to complete this part of the operation. As is customary when performing any anoplasty, it is prudent to make it about 25 to 30% larger in circumference than the final expected size of the anal opening, as we know that the circular suture line will contract down by about a third. If the anal opening is adequate to start with, then a long sequence of troublesome anal dilatation can possibly be avoided. We have thus completed the anoplasty, and after a light wash of the peritoneal cavity, the abdominal wound is being closed. You will notice here that there is a small proximal ileostomy, which was done as the preliminary procedure for this patient outside the hospital, and we therefore do not need to create a further ostomy to protect the distal stapled suture line. Post-operatively, oral intake was allowed as soon as the ileostomy started functioning, and the patient received 5 days of cefotaxime and metronidazole. Colostomy closure was planned at 3 months.